Good afternoon. Andrea and I, believe it or not, we're great friends. We often talk about disparities, but we haven't touched base once since we decided to do this together. And what I think is sort of wonderful is that I think our two talks really will complement each other. As an epidemiologist, of course, I am sort of looking through sort of a lower power, kind of that broader view, and we'll really kind of talk about cancer disparities using broader strokes. But I think that it will be more meaningful having sort of this level of detail that we've seen right here in New Haven. What I want to say a little bit is that the impetus for this talk is that I was recently invited to provide testimony to the President's Cancer Panel, and who would have guessed that Richard Nixon would be named twice in 1 hour? But when he was president with the war on cancer, they established the President's Cancer Panel, and by law they're mandated to take on a theme each year and provide for, they conduct 4 meetings in each series. And this year, the series is really to consider the implications of the socio-demographic transformation of the U.S. population on the cancer enterprise. And as an invited speaker, I was asked to talk about my work on breast cancer disparities, which is mostly population-based here in Connecticut, which is exclusively population-based here in Connecticut. And so what I've done is try to draw from that the lessons we've learned from that experience, as well as the knowledge that others, not just my research, but others, research as well, and then to apply that in a more speculative fashion to sort of what are the issues that we're going to be facing in terms of cancer disparities with respect to the changing demographics in the United States. And in particular, I'm going to be talking just about breast cancer, not as broad a perspective as Andrea took, but I'm going to be focusing primarily on Hispanic Latinos, and for a number of reasons. But before I get going, sorry about that. I don't want to end show. I want to do this. I'm going to be presenting sort of a broad view of cancer disparities. It's too broad to discuss all of it, so I'll be focusing on areas of vulnerability, and particularly those in which we can imagine that the Hispanic Latino population will be affected. And then we will also, hopefully, as I go through, and then also at the end, talk about opportunities for intervention so that we can preempt sort of furthering or exacerbating the disparities problem. Just a starting point, Andrea referred to this at a local level, but certainly on a national level. The populations, we're in the midst of the greatest immigration, massive immigration that we've seen in many, many years, with Hispanic Latinas projected to represent about 1/3 of the U.S. population by the year 2050. At that time, too, whites will clearly be in the minority. In fact, there's this interesting language where it'll be the first time when the minorities will be the majority. So I don't know what that means exactly, but it's a lot of curious language when you talk about health cancer disparities. The other thing is that we, specifically the Hispanic Latina population, will triple in that time period. And what we know is that about 46% of the foreign-born population currently are Hispanic Latino. They come from all parts of Central and South America, but are overrepresented certainly by individuals coming here from Mexico. And then there's another aspect to this whole piece, which is, as indicated by Andrea, and I'm sure you're aware of, this population shares, these are Connecticut data that I'm showing up here, but they are overwhelmingly underinsured as well as lower socioeconomic status. So the median household income for whites is about, in Connecticut, is about $73,000 a year, about $45,000 in African Americans, and about $39,000 in Hispanic Latinos. And again, there are striking differences in terms of insurance. Okay, so that's sort of the starting point. Just to give you, as I said, I'm talking about breast cancer. The issue around cancer disparities in breast cancer, we've always focused on mortality rates or differences in mortality. But if you look in the green here, you will see the incidence data. And whites are at highest risk for breast cancer, followed by all other groups. And I think what's sort of interesting as we move forward and sort of trying to project what the disparities problem is going to look like down the line, is that we may want to be taking advantage of this incidence advantage in these other population groups. Traditionally, in African American women, their advantage has been chalked up to the fact that they are they have different they differ from whites in terms of the reproductive risk factors. So they have higher parity, earlier age at first birth. In years past, used to do more breastfeeding. That's no longer the case. They certainly were less likely, African Americans are less likely to use hormone replacement therapy, although that's certainly not as common as it once was. And so the question is whether or not those same factors, which are true of most of the other racial ethnic subgroups, will offer a protection, and whether we are going to be able to maintain that advantage given the fact that obesity is also a risk for breast cancer, and all of these groups also are disproportionately overweight or obese. So we'll come back to that a little bit. But just want to look, these are data looking at, there's one exception to the incidence being higher in whites compared to African Americans, and that's at younger ages. It looks it's subtle, and in fact breast cancer is rare in younger women in general. But until about the age of 45, African American women are at higher risk for breast cancer. And these are data that Louise Brinton put together from the SEER system, and you can see that actually, while it's very rare in young women, among women who are less than the age of 30, African American women are about 50% more likely to be diagnosed with breast cancer than are whites. So this actually, speaking to clinical, sort of anecdotally, I know from presenting to groups of African Americans, one often hears stories of African American women, young women who went to doctors with concerns about symptoms, lumps in particular, and were told that they were too young to get breast cancer. So certainly just making clinicians aware that it does occur at young ages. It's rare, but it does occur. And probably of more concern and relevant to the topic today is that we are seeing the same pattern emerge for Hispanic Latinos. So we're seeing cancers diagnosed at younger ages. All right. Certainly, if we get back to this issue of race differences in mortality, certainly a major driver are the race differences that we see in stage of diagnosis. So these are SEER data. They are the most recently available data, and these show about 62% of breast cancers in whites being diagnosed when the cancer is localized to the breast, and that compares to about 51% in African Americans. And then if we look at this same figure for whites, in Hispanic Latinos, this figure is about 54%. So two things are going on without a clear explanation why, which is Hispanic Latinos, like African Americans, are diagnosed at younger ages, and they are diagnosed with later stage tumors. And then adding to that is the fact that if we even control for stage differences, so these are all women with the same stage cancer, we still see 5-year relative survival rate differences between groups. And so these are data just showing African Americans and whites. So at all stages, African Americans don't fare as well as whites, but we're seeing the same pattern emerge for Hispanic Latinas. Okay, I think since you've heard it from Andrea and myself, I'll skip through the summary. So this is sort of the problem. We see that the incidence rates are lower in other racial ethnic subgroups compared to whites, but their mortality rates are higher, and there's significant survival differences. So how do we break this apart? And as indicated, probably a primary driver of this sort of phenomenon are the race differences that we see at stage of diagnosis. And what I'd like to do is just show you, it's not an exhaustive sort of framework, but there are factors that probably exert their influence across on both stage of diagnosis and race differences in survival, but there are some that we can identify that primarily affect the race differences we see at stage of diagnosis. So what are these upstream factors? They're ones that Andrea, I don't even need to speak about because I think she very eloquently described how they impact breast cancer outcomes. So certainly they're rooted in differences in socioeconomic factors, sociocultural factors. What I do want to call your attention to, though, are some that are specifically relevant to Hispanic Latinos. And while we talk a lot about the role of racism, and racism is, yes, there's overt racism in the healthcare system. It may be sort of a different version of that. But it's also a notion of institutionalized racism. When it comes to Hispanic Latinas, the issues may be more around discrimination. It may involve skin color, but probably also apply to discrimination based on just immigrant status or language issues or speaking with an accent. So there are other factors there. We also, there are certain, I think Andrea also talked about this a little bit, this notion of acculturation. Very curiously, people when they first come to this country are healthier than the general population. Second-generation immigrants are less healthy on a number of risk factors, both the health behaviors as well as just outcomes, than first generation. And even for individuals who are first-generation immigrants, the earlier that they come to the United States, the less healthy they are. This speaks to the fact that there's this real downward sort of mobility in terms of socioeconomic status that affects most immigrants coming to this country. Not all, but a fair number, and certainly does impact Hispanic Latinas. The other factors that are of real concern, sorry, I think these circles got messed up, but and are relevant to the issue of Hispanic Latinas is that they, in addition to the usual socioeconomic sorts of barriers, there are language barriers, there are issues around literacy as well as health literacy. Anecdotally, in a study we're doing now, we've had to change our entire patient enrollment strategy. We're looking at mammography screening in Hispanic Latinas. And because we found out just that very few women, well, not very few, but there was a significant problem with just literacy in their own language. So it wasn't about just providing materials in Spanish. It was that we had a lot of women who just simply did not read. So that's an issue. And then there are issues about just sort of cultural sensitivity and cultural competence. So just sort of to lay this out, these are this is sort of, I want to drive home the point that the issue around any sort of disparities problem is complex. What we see here are factors that may exert their primary influence on stage of diagnosis and others may impact survival. There's a lot of attention right now, and a lot of excitement around tumor characteristics, race differences in tumor characteristics. And we know that there are great opportunities here in terms of gene expression profiling, and we've made great progress in terms of understanding differences between African Americans and whites. These are data that we, based on a Connecticut population-based study that we published some years ago, and it was before the sort of labeling of triple negative. But just looking at women who were both ER and PR negative, there was a significant race difference with African American women being more likely to have these more aggressive tumors. And we also identified very significant race differences in P53 mutations. All of these, and they're interesting, and this is true, even though we talk about the triple negative being ER, PR negative, and HER2 negative, there really are not generally significant race differences in HER2. The reason these are important is that we've now realized that these triple negative tumor types actually are not a perfect proxy for, but they tend to be basal-like tumors, and they overall have a poor prognosis. We're seeing them in African American women disproportionately, particularly premenopausal breast cancers. Unfortunately, we also are seeing this described among Hispanic Latinas. And curiously, we are also, now there's a study out of Appalachia in which the population is overwhelmingly white, but what they have in common with the Hispanic women and the African Americans is that they're overwhelmingly poor. And they're showing triple negative tumors that are sort of commensurate with the proportions that you'd see in African Americans. And then the other factor that we've seen in triple negative tumors, is that they're more common among obese women. So all of these issues speak to the fact that we're in the middle of a massive sort of immigration trend in which a lot of the population coming into the United States is going to be disadvantaged in terms of socioeconomic status, as well as some other health factors such as obesity. This is a table put together by Vona Davis and David Rose, looking. The problem here is that we don't have triple negative data on, there's one group that has it on Hispanic Latinas, but we don't have the same depth of data on other groups as we have on African Americans and whites. So this is just looking at ER negative tumors. And what's very interesting is across all of these studies, these are fairly large populations, we see that the highest proportion of ER negative tumors occur in African Americans, the lowest in whites, and Hispanics are right in between. Okay. I just want to talk very briefly about some of the other factors, now just focusing on some that may impact stage of diagnosis. delay, described as either patient delay or clinical delay, has been it gets repeated a lot in the literature as a primary driver of the later stage of diagnosis and the worse outcomes in African Americans compared to whites. We've done some work on this as well, and generally my feeling is that while delays are really critical and correcting these delays for individuals is important for their outcome, on a population scale, we don't usually see this as a big explanatory factor in explaining why some groups are diagnosed later in their illness. And part of that is that the actual delays that are generally documented it's not clear that they're clinically meaningful. One recently published study showed a delay of 8 days in clinical diagnosis. And in our own work, it was about 17 days. So does this sort of a delay on average make a huge difference? I guess that's the question. The reason I bring it up here, though, is I think with the influx of individuals coming from countries where they have a different healthcare system, there may be less awareness of breast cancer in general and breast cancer symptomatology. It may be and certainly screening, it may be really important that we may start to see delays that are clinically meaningful in some groups. And so we probably need to stay on target in terms of prevention and getting those educational messages out, and of course tailoring them to the population. Just to speak a little bit about some biomedical factors, there are a lot of factors here. Andrea talked extensively about comorbidity. I just wiped out my obesity one, but that's the one I want to talk about. So obesity, as I said, affects other racial ethnic groups, although that's in the past. Right now we know that it's of epidemic proportions across the entire U.S. population, with about 60% of whites being either overweight or obese, about 70% of African Americans, and 62% of Hispanic Latinos. And so why is this important? Well, we know that obesity is associated with stage of diagnosis. It's associated with survival once we account for stage of diagnosis. And in fact, in some population-based work here, my group, and then we were able to repeat this finding with the Carolina breast cancer study with Trish Moorman. Just by accounting for the excess of obesity in African American women, we were able to explain about 1/3 of the later stage of diagnosis. And we found the same thing in the Carolina breast cancer study. And in fact, in that study, we had the advantage of looking at upper body adiposity, and that seemed to be the driving factor. So again, obesity is certainly a factor that is intervenable, can be modified, and certainly has implications for driving these worse outcomes in some groups, as well as in whites, certainly. And then finally, I want to talk a little bit about the screening differences. Here in Connecticut, we've done a lot of work looking at race differences around screening. And the tricky thing here is that when you just look at the self-reported survey data on past screening, it's fairly optimistic. A lot of African Americans and whites seem to screen about the same levels, and Hispanics lag a little bit, but not that much. But in spite of that, we don't see that in some previous studies, it's never been shown that if you adjust for race differences in screening that you can explain a lot of the race differences in stage of diagnosis for African Americans. So we asked the question as to whether or not, even though people are getting screened, are they getting the full benefit? And I'm just going to skip quickly to the results of 3 main pieces of this study. The first question was, obviously just having had a screening exam in the last 2 years is not sufficient. What is really important is that a woman gets regular screenings at the appropriate intervals. So we looked at adherence to screening guidelines. What was shocking was, as you can see, the proportion of all women who were getting screened regularly was fairly low. It was around 50%, but there was a race difference. Then we looked at the communication of mammography results, thinking if we want women to be partners in their health care, they really need to get their results, know what the results are, and deal with that. And what we found is that African American women were much less likely to either receive the results or to report the results accurately. And unfortunately, when their results were abnormal, they were much less likely to know those results than when they were normal. So that speaks to the fact that these women are not getting the full benefit of their screening mammograms. And finally, in the case of abnormal exams, certainly these are not all breast cancers, but they are mammograms that need to be followed up if someone's going to get the benefit of having been screened. And what we see are striking race differences, with African American women 3.5 times less likely than white women to get adequate follow-up when they've had an abnormal exam. So these are all factors these are data that were published a few years ago, and I think what we've seen is some of the interventions are not just from these data, but we now use patient navigator programs and case management systems, not only at the level of diagnosis, but also in the screening setting. And there's some very simple things, I think, around inadequate communication that can be done at the time of patient enrollment, simply confirming addresses and determining the best way to communicate with patients. Just to say, we are now in the middle of a new study where we're looking at similar issues in Hispanic Latinos here in the Northeast. The problem is that the data that exists for Hispanic Latinos has been primarily come out of studies that were conducted in the Southwest or maybe in Miami. So we really don't know a lot about screening behaviors and a lot of outcomes here in the Northeast. So I have a great group of co-investigators and staff members, some of whom are here. So we are just started the second year of that study. So just to, this is a way of recapping if you want to know. I wanted to end with this, it's not quite the end, I'm lying. But it does speak to the complexity of the issue, and while I think it's just wonderful that we're making great progress in terms of identifying methods of treatment based on understanding better the tumor characteristic differences across racial ethnic groups, I think there is a whole lot here which also can be addressed and that we know a lot about, and certainly should be taken into consideration if we want to avoid sort of the deepening disparities that might come with the changing composition of our population. So finally, just to also point out, even though right now, in terms of incidence, Hispanic Latinos have lower incidence rates, increasingly they are going to represent a greater proportion of the breast cancers that you're seeing in the clinical setting and that we see in terms of the data, because their numbers are increasing. They are aging, so they're getting to the age where women are more likely to have breast cancer. And also over time, we will see this group, they generally tend to adopt the higher risk breast cancer risk factors, so that they will delay childbearing. I mean, this may be good for all kinds of other reasons. They are probably going to delay childbearing, have fewer children, and things which actually offer a little bit of protection right now. There are some, there are opportunities in terms of primary prevention. Actually, Hispanic women traditionally aren't big users of alcohol, but certainly to continue with those messages to deal with exercise and obesity. The other thing that I would want to point out is that the disparities in breast cancer outcomes result from group-based differences across a wide range of factors, and that all of these really there are multiple influences, and the influences that we talked about as being sort of upstream, the socioeconomic influences, are going to be with us unless something very dramatic happens in the near future. So I think that we want to stay focused on that issue. In terms of sort of secondary prevention in terms of screening, this is not, we know, you probably are well aware that we have different sorts of screening guidelines. Some are promulgated by the American Cancer Society and others by the NCI. It's very subtle, but the NCI guidelines call for screening for women in their 40s every 1 to 2 years. The ACS guidelines, it's subtle difference in language, require that, or suggest that women upon turning age 40 begin receiving annual mammograms. And I think when we're talking about populations for whom their cancers are more aggressive and they are diagnosed at earlier ages, it's really critical that that screening technology, as imperfect as it is, that we begin screening women at age 40 and do it annually. I want to just mention again that there are very unique challenges that we need to take into consideration given the change in our population. These have to do with those issues that we spoke about acculturation. Some groups, what we know is they may come to this country in fairly good shape, and within a few years they have, probably due to drifting towards lower socioeconomic status rankings, they don't do as well. There are going to be significant challenges in terms of literacy and health literacy, and also we need to kind of keep our eye on discrimination and a related factor which has to do with the residential segregation which occurs in our country. While there are many benefits to living in enclaves of people with similar cultures, sometimes that becomes very isolating and does seem to impact health as well. And then there are the familiar challenges that we've been dealing with right along, which have to do with the lower socioeconomic status that we see in almost all non-white groups. Finally, I would say that in terms of the biological, there's sort of this false tension between biology and social factors. And there's not one answer. Clearly, we need to work from both ends of this. But the fact that we start to see these same biological characteristics play out across very diverse populations that share the one thing they share in common is lower socioeconomic status, I think speaks to the fact that we need to be addressing the cofactors that are impacting these outcomes. Finally, these are just black-white differences, just a reminder that we have a lot of, we're making great progress, but there's a lot of room to improve. The current 5-year relative survival rates for African American women is about 78%, and that's about what it was for white women when we started collecting data in 1975. So I think if we want to avoid seeing Hispanic Latinas in this same situation, we probably need to be thinking proactively. So thank you.